And any questions are welcome. Yep. Thank you.
Hi, I'm Pamela. I'm a patient and I'm part of the Betsy Cadwallader unit. My journey was made, in my opinion, slightly harder because I was initially diagnosed as possible cholangiocarcinoma in Wrexham, but they still sort of kept me and were doing investigations there, and eventually then I moved over to Liverpool. So, and then from when I was in Liverpool were telling Wrexham what scans to do. So I had that. So they had to be reported there, and then back to Liverpool. So my question is, why, when it was picked up on an MRI scan very early on, did I not immediately get transferred over to Liverpool as part, and then just dealt with by Liverpool?
I think, I mean, I've got some colleagues from Liverpool here,
Yeah.
but I can, exactly the same experience probably from West Wales patients for Cardiff. We just cannot scoop everybody up and bring them in. We do not, and this is going to be replicated, I'm sure, across HPB units around the country. We're not set up to take in all these external patients for investigation and workup. Would I love it? Would it be on my wish list if I could scoop everybody up with cholangiocarcinomas? We just can't. We wouldn't be able to provide a service. Do we need to have everything improved and streamlined for those patients? Yes, absolutely. But you're not. That is, I think, a very common experience to anyone who is diagnosed outside of an HPB centre. I don't know if Hassan is here from Liverpool. You might have. No, there he is.
Hassan, you can come up and have a bit of the microphone if you want.
We know each other well. I think the problem is essentially that it's kind of hub and spoke model, and there's diagnostic issues to start with. But once that diagnosis has been made, then we try and streamline care. But often the care is complex, and then you're going to go back home and recover, and if you need to come back, etc., they're asking for repeat investigations, bloods. Trying to get a GP to do a blood sample is sometimes really challenging. It's easier to get you to come all the way back to Liverpool to a clinic than ask the GP to do it. But when you're crossing these boundaries, it is difficult. And from a rehab point of view as well, it's a big problem for patients, and so, and it should, I mean, the guy from NHS England's gone now, but these are actual real world problems that patients face.
Can I be more provocative? Should Wales be treating cholangiocarcinomas anyway?
Ooh.
There you go.
What's the numbers? What's the evidence? Trish, back to you.
Yeah, back to me. I promised to come back to MMF and actually bring you. This is the first time I've been. Like I said, we felt a little bit out of the loop in the context, but I will come back with numbers and data for you because we think our outcomes are of a par with other centres. So I will bring that back to you and the numbers. The overall data collection in Wales is very poor, as I've highlighted, but we do have good surgical data because we keep it. But not everybody gets to surgery, obviously.
Jane, congratulations on your study. I was intrigued by the number of patients who had GemCis as adjuvant because, as you know, there's no evidence that it works as adjuvant. But there was a trial running comparing CAP and GemCis, which might have impacted upon these data. I mean, do you know how many were managed on trial and how many were just empirically treated with GemCis?
I suspect the majority of those on the GemCis were trial participants. We did collect that, and most were on study.
Close to the microphone, please?
Yes, so most were a part of the trial.
Yeah, that trial should be presented at ESMO in October, so it'd be good to see the end of that.
Thank you. My question is to Jane. Also, again, congratulations on the presentation of the data. You presented the increase in the utility of PET-CT scans, and you gave the results of uptake with the primary tumor and the lymph nodes. But one of the main reasons for doing the PET-CT scan is to identify distant disease, and then patients don't have unnecessary surgery. Are you able to comment on any numbers that you have from there?
Unfortunately, because we looked purely at those that had come to resection, that was the data that we had collected. We therefore we never captured those that were excluded because of distant mets, because of PET. So unfortunately, we didn't have that data.
Thank you.
Yeah, hello, a great presentation, thank you. My question is for Julien. Very beautiful overview. I was wondering what's the situation of the combination of chemo and immunotherapy and CERT. Can you please comment on that?
And if you can also mention how will you combine with CERT and the timelines, Julian, which is your recommendation?
Yes, so the timeline for combination with chemo, so in the trial we do that concomitantly, but there based on the phase 1, we decreased the dose of gemcitabine because of concern about potential radiosensitivity, radiosensibilization. So for the cycle before and after CERT, we do decrease gem, but we do that in between. So CERT might happen whenever possible during the cycle, and this appears to be safe. For the combination with immunotherapy, in intrahepatic there is no data, but for HCC there is data of the feasibility. No clear data showing that it's improving outcomes. So we do that in practice in France, and we will provide retrospective data on the feasibility of that. Albeit I don't really know whether that might improve outcomes.
There is also a recent publication, collaboration between ESMO and ESTRO on recommendations for adjustment of those with radiotherapy. We need, in a way, could help. And immunotherapy doesn't seem to be a concern, but still.
Hi, question for Julian. Thank you all, the panel, for amazing talks. So I'm Julian, I'm a hepatologist, so I get called in when people's liver decompensates, and my colleagues overestimate me and my colleagues' ability to effect recompensation. But my question was with CERT, and at our centre at Imperial in northwest London, we're doing more and more CERT. It's so well tolerated, and for those big tumours, it's very good, and you don't get the embolization syndrome because you're not embolizing. My question is, how often do you think you see really serious life-threatening radiation-induced liver injury, and are we getting any better at predicting who might get it?
We see that less and less. In previous areas, we used to see radioembolization-induced liver disease, but we do see that less and less. We have made more difficult threshold, especially for bilirubin. So recently we published for HCC another study showing that bilirubin is main predictors of REALD, so in HCC, but this might be relevant also for intrahepatic, and so we decrease the threshold of bilirubin to 26 micromolar. For CERT in intrahepatic cholangio, there were two settings where we do see decompensation. So cirrhosis I talk about, especially when we try to combine with chemo. In the prospective trial, we do see that this is not going well, so we don't do it anymore. If we discuss CERT in intrahepatic cholangio in cirrhosis, we do chemo first and then CERT with no concomitant treatment. The other situation is when patient needed stenting, biliary stenting, and we did see liver decompensation in patients with biliary stenting, even if bilirubin has decreased. So this is the other setting. currently, when we select this patient well, with normal bilirubin, no cirrhosis, no low bilirubin, I don't see any decompensation anymore. So it's selection of patients.
Thank you.
We allow you, John. Go ahead.
Thank you very much. Excellent talks. Just a supporting comment for Trish, really.
Thank you, John.
My impression from my end, from the molecular aspect of doing the tests, from putting patients on the studies, is that devolution is not working for these patients. So I have tried to. So the molecular Wales lab, I have approached on many occasions to see whether they will do the English panel. Otherwise, there is a lottery, and patients notice this, and they will not. They will not. They've said that that's too difficult for them to do. So that makes it very difficult. Study-wise, patients travel to London to come on to study, and I think that's really, really difficult. Even to put them on the study, we have to get permission from NHS Wales for them to be treated with the standard of care in England. So, and I do not know how to sort this out.
No, but like I said, we've just had an election. I'm looking at Helen and AMF for some support because we need some big changes so that we can help our patients.
Do you think, John, that opening those trials in Wales is a possibility? Because in Spain we have a similar issue as well, and sometimes we have people asking, let's open the trial in this place. The problem is the performance is not always great in those sites. So you have a balance between being closer to the patient but also having people who have an expertise on clinical trials. What do you think is?
We tried to open the study in Wales.
You tried?
Oh, yes.
And
yes.
It couldn't, no?
It was declined, yeah.
Okay.
Yeah.
We have a couple of minutes more if you have more questions.
Yeah.
We can.
If anybody else wants to come up to the microphone while you're looking or thinking about some other questions, because I just asked Jane about her study, the CAPBIL study. I'm just intrigued by the variability between the surgical centres. As those of you who read guidelines are aware, the quality of guidelines is very variable, I would say, from poor to very poor. But there are exceptions. So do you think that the variation in clinical practice is because the guidelines are poor or the evidence behind the guidelines is poor? I'm interested, for example, in the lymphadenectomy rate. And if you look at the evidence base, correct me if I'm wrong, but look at the evidence base behind lymphadenectomy for intrahepatic cholangiocarcinomas. It's not trial-based. It's based on cohort studies. Could you maybe comment? Do you think that we're ignoring the guidelines that are good quality, or do you think people are genuinely doing what they think is right because the guidelines are poor?
It's probably a combination. As a surgeon, we're creatures of habit and may learn old habits from mentors who have maybe not followed the guidelines and moved with the current recommendations. Lymphadenectomy has not been shown to have any influence on survival, but what our study has shown, it's consistently the most important prognostic factor for our patients with intrahepatic cholangiocarcinoma, and I think we need to get that message out there as surgeons that we should be doing a lymphadenectomy more for prognostication in these patients and to make sure that they're watched more closely and receive the appropriate adjuvant treatment.
Jane, do you have, I think you mentioned the R1 resection rate, that was coming down, right? Do you have an explanation for that?
Well, I think when you looked at the cohort, in the more recent cohort, they were T1, T2, there was a higher proportion of earlier tumours, and there was also fewer multifocal tumours. And reflected in that was the fact there were fewer major liver resections performed, so that would indicate that these are potentially smaller, more peripheral tumours that we tend to get clear margins on. So there might have been, again, like a lot of these things, there's a number of factors, and with a retrospective cohort, we can only but assume that those are what's contributed to
But
it.
maybe a better patient selection?
Potentially that as well.
You know, when systemic therapies improve, sometimes we move more into systemic therapy when we think the resection is more challenging. Do you think that may
And
be
potentially
happening?
with the pre-operative staging and the addition of PET, you might have been more aggressive in your approach and potentially.
But the absolute number of surgeries you had was very similar, right?
Yeah. Okay.
Can I have a question for Julian, please? So, surprising how good the data is in CERT, given that it's not genuinely available or generally used. So do you think that that's because it's a complex intervention and there's not enough people available that have the expertise to do it? Or do you think that they don't believe the data that's there?
I mean, if we are objective on the subject, the level of evidence of data is quite poor. I mean, the largest prospective trial is 41 patients, single arm. So yeah, I'm convinced these are real data. I produced it, but yes, it's a single arm phase 2 trial. Having said that, I think this is more how this data is interpreted, especially in terms of reimbursement of the techniques. There are different rules across different countries, sometimes different regions within the same country. And some, for example, in France, well, they found this sufficiently convincing to fund, and we can do that for every patient right now. But depending on how you interpret that, this in other settings was not found to be enough for reimbursement. And if you don't have reimbursement, you won't get large intake. In France, there is a large intake. I mean, I've referral frequently for doing CERT from other centers that are not doing CERT because they are convinced, but that will depend on the countries.
Okay, thank you.
Thank you. I think we are going to close this section. Thank you very much to all our speakers. Thank you.